Good evening, Dr. Purdy. I didn't get to introduce myself yet. My name is Brittany, and I'm one of the Interprofessional Community Health Program Coordinators. Nice to meet you.
Nice to meet
Um,
you as well.
and our program it basically has two main focuses. The first focus is on interprofessional interactions. So we get students from medicine, from nursing, from OT and PT, and we sort of get them to work interprofessionally in that way. And the second focus is on working with vulnerable populations. And I think Minnie has mentioned that our previous talks have been about seniors and how they've been impacted through COVID-19, and another one was on the homeless population. So that's kind of the little spiel about our program. And the talk that you're doing today is actually part of that program. So we have a couple of participants here today that have signed up for that program, and this talk will go towards completing that program and ultimately earning them a certificate at the end. So thank you for your time.
Yeah, you bet. Happy to be here.
So probably wait a few more minutes and then we'll get started.
And the people who are working towards the certificate in the program, can that be in any of the professional schools?
So currently this year we're running sort of a mini version of that program. We're still kind of in the middle of sorting everything out. And for this year, we've opened it up to all students in the Faculty of Health Sciences. So they don't necessarily have to belong to nursing or to medicine. They can just be a student in the Faculty of Health Sciences and they can participate in the program that way.
Cool.
Okay, so why don't we get started now? And if people trickle in, they'll trickle in. And everything is being recorded, so we do hope that we'll be able to get this out onto our website and onto our Facebook, and then people will be able to watch it who aren't able to come today. Okay, so hello everyone and welcome to the December edition of KHealth Speaker Series. The title of today's talk is Doing Our Work Better Together. So Dr. Purdy has given a few lectures before to medical students, so some of you here may know her and some of you here have may even worked with her before. But for those of you who haven't, Dr. Eve Purdy is an associate professor in emergency medicine at Queen's. She is also an organizational anthropologist and she does research on how teams from trauma to obstetrics to rapid response can do their work better together. So thank you all for joining us here today, and let's give a warm welcome to Dr. Purdy, who's here to help us better understand how relationships affect the work that we do every day. So without further ado, I'll hand it off to Dr. Purdy.
All right, I am totally thrilled to be here. In fact, this is exactly the type of group that I think we should be having these conversations with. It's a bit silly to be talking about teams and functioning in our silos that exist in training and really in our workplaces. So it is so cool that you guys have started this group and really kind of come together and built something pretty neat. In fact, you could probably be giving this type of talk, and it's exactly this type of work and this type of attitude that I think will allow our teams to be stronger even down the road. I apologize in advance. My apartment right now is a total disaster because I am I'm in the process of moving, so it's a bit of a mess. But hopefully we can have some good conversations. Anyways, I'm hoping that this can be a pretty relaxed discussion. I'm going to start by kind of sharing a couple of anecdotes and stories that really highlight what I think is a super fundamental principle in how teams work well together. When I am doing that, I hope that we actually might be able to expand our understanding a little bit of what the healthcare teams are. So we're all sitting here as folks who are either in professional schools or in the Faculty of Health Sciences, but two of the stories that I'm going to tell you actually are about other members of our team, and really important members of our team that I think sometimes we forget about and overlook. But for me, are experiences that have really stood out and made me rethink about the way that we think about teams and how we can make them stronger, really at the end of the day, to provide good patient care. We will kind of hear about those stories. We'll learn about one really fundamental principle in team function. And then I'm hoping that we can just have a little bit of a chat about what this means for us in our school, in our workplaces, and perhaps have a bit of a discussion about where we go from here and what we can do with it all. I would totally encourage you to pipe up and put some questions in the chat, or if you want to stop me partway through, that's totally fine. I have no hesitation to kind of stop and change things and answer questions as we go. But to kick us off and get us started, I am just going to share a couple slides here and tell you a couple stories. As an anthropologist, that's really what we do. People always kind of wonder what anthropology is, and it's the study of culture. So I study teams, the study of culture, and really the way that anthropologists do that is through data-supported storytelling. So I'm a fan of stories, and here are a few rooted in my experience as an emergency physician, but also in some of the research work that I've done as an anthropologist. So let me just do something here. This is not what I want. I'm gonna go like this. All right. So this picture might look a little bit familiar to anybody who's watched the news over the past 9 months as we've been dealing with COVID in our hospitals and around our world. As an emergency physician, this is really the sharp end of COVID. This is a picture, actually, I think that somebody took of me at KGH as we were getting ready to intubate a patient who was in respiratory distress in about March, I think. So really when we didn't have a great understanding of exactly what COVID meant for our community. Now our rates are pretty low. But at this moment, there was so much uncertainty and so much fear and all of these new processes and all of this new PPE that this is a moment that really stands out for me. This was the first COVID intubation that I did as an emergency physician. And this was all new. This was all different. There was a degree of kind of personal safety risk associated with this. Now, this wasn't a COVID positive patient because we don't have any in Kingston, or didn't have any in Kingston in the spring. But we didn't really know that at the time. We didn't really know how this was all going to pan out. So while our department was kind of ramping up to prepare us for what was to come, we had developed new checklists, we had developed new airway teams, we had thought about how we're going to don our PPE safely and doff our PPE safely. And we spent a lot of time going through this. It wasn't perfect, but we thought we were doing a pretty good job. Now, in and amongst this kind of upheaval in the emergency department in the spring, as my role as an anthropologist, I actually spent time involved in a project where we spoke with just about everybody in terms of roles in the emergency department about their experience, about what they were worried about what they thought we could be doing just a little bit better. And so over the course of kind of the first 8 weeks of our response to this pandemic, I had about 55 interviews with different members of our department, ranging from porters to respiratory therapists to paramedics to physicians to nurses, about how they thought things were going. We also had 10 of our staff doing kind of structured shift reports. And we used all of this information and collated all of this information to give back to our leadership once a week to help inform their decision making. Now, it was a real opportunity and a real privilege to speak to my colleagues during this time and curate their stories. There's all sorts of interesting things that came from those conversations, but the moment that really stands out in my mind is a conversation that I had with one of our environmental services experts. Now, this isn't necessarily somebody that we would instantly think about as being on our team. I mean, I show up to the emergency department and I see them every day, and but I guess until this moment, I hadn't really thought of them as a or internalized them really as a key member of our resuscitation team. And I think that was a mistake. I know that was a mistake. So I sat down with this environmental services expert, and she is a woman who falls into a high-risk category of people for COVID. She's over the age of 60, but she's showing up to work every day and working in the COVID section of our emergency department. And so I went through our kind of standard questions. What do you think is going well? And I asked her, what are you worried about? As I conducted all of these interviews, many people were worried about their own personal safety. They were worried about their kids not going to school. They were worried about finances. This environmental services person told me that they were worried about the physicians. And they said this was why. So she told me she was worried about the doctors because she noticed that they were taking their PPE off incorrectly when they were coming out of the resuscitation rooms. That easily could have been me coming out of that resuscitation room, taking off my PPE incorrectly. Now, this is important because we know that during the doffing phase, when you're taking off PPE, is often the time when healthcare providers actually get contaminated. And so she saw this happening and she was worried about it. So being an anthropologist, I dug a little bit deeper. We talked a bit more about it. And then I said, have you told any of the docs that you noticed that this is happening? Have you stopped them? And she told me that she wouldn't say anything to anybody because I'm just a janitor. I'm going to let you sit with that for a second. I'm just a janitor. That amount of pause is basically the same amount of pause that I had in that conversation with her. I was totally taken aback. And I felt like I had almost just been kind of hit by a truck. In part because I know that being on the opposite end of that, I would have wanted to know that I was doing this incorrectly. I was taken aback because as somebody who works a lot in teams and works in the emergency department, I like to think that we have a pretty good culture and that we've got a pretty good group. And that people would speak up if they saw something going wrong. But I realized in this moment that just wasn't totally true. And then I got to thinking about another experience that I'd been involved in. This time it was when I was actually doing a fellowship on the Gold Coast of Australia, and I was studying the culture of trauma teams. And while I was doing that, I was involved in a number of kind of high fidelity simulations. And one simulation involved a very agitated trauma patient. So it was a trauma patient who had been stabbed, but who was quite agitated and potentially dangerous in the resuscitation room. And the room looked a little bit like this. What you can't see in this picture is that just kind of hiding in the corner, and he's just blocked by this paramedic and the doctor. is a security guard. So because this was an agitated patient, we thought we would have the whole team there, including security. And so security was there. The simulated resuscitation went pretty smoothly. We got this gentleman off to the operating theater to be looked after. And after the simulation session, we came together as a group and talked about how things went. There's some of the surgeons there talking about the intricacies of managing his stab wounds. There is the anesthesiologist and the emergency physicians, and they had a long and interesting discussion about what was the best medication to kind of chemically sedate this gentleman because he was so agitated. And we were just about to wrap things up, and I was kind of sitting beside the security guard, and he leaned over to me and he said, I'm feeling a little bit uncomfortable. And I said, well, what are you uncomfortable about? And he said, well, we were in that resuscitation bay, and it was, about 15 or 20 minutes before this patient was intubated. And the whole time I was worried that he had a weapon. I never got the chance to search him. And I was worried for the doctors. I was worried for the nurses. I was worried that something bad was going to happen. And so we decided, him and I kind of together, that we would bring this up in front of kind of the bigger group, because at the end of the day, this was actually a totally crucial moment in this case. And when the group got to talking, there was a little bit of a discussion about, why didn't we talk about this in the room? Why didn't this come up? And he said, I didn't think it was my place. I'm just a security guard. And he felt like he didn't want to interfere in what the medical team was doing, because that was so much more important. Meanwhile, the medical team is sitting there going, oh my God, they're seeing their life flash before their eyes, not even thinking about the fact that this guy might have had a weapon, and are kind of having that same moment that I had when I was talking to this environmental services expert, that they were so blindsided by their understanding of the situation being so different from somebody else's in a really crucial way. What we start to paint a picture of is that this kind of situation with the security guard and the situation with the janitor, they're actually not so different after all. They are fundamentally rooted in a very important concept in team science, and it's this idea called psychological safety. Now, psychological safety isn't just being nice to each other. I'm very nice and pleasant to the environmental services people in the hospital. I'm quite nice and pleasant to the security guards. But that doesn't go far enough. Psychological safety is a concept, or this idea, that people within a team have the ability to take interpersonal risks. So the janitor, despite just being a janitor, feels like they can take a risk and tell the doctor that they're doing something wrong. That the security guard feels like they have an important enough role in this resuscitation bay that they can interfere with the medical management of the patient to say, hey, I've got something that I think is maybe a little bit more important, or maybe you've not thought of. It usually requires us being nice and civil to each other, but it requires something a little bit more important than that. A realization and an understanding that every single person on the team brings value, and incorporating that into the way that we interact with each other and the way that we interact with our teams. These are two very obvious examples. They are at the high end of the spectrum of safety, physical safety for the team members involved, and kind of, dramatic examples of psychological safety in action. But if I think back to my shift last night, I was working in the department overnight last night, and just off the top of my head, I can think of 3 specific examples where members of my team had to take an interpersonal risk that allowed us to provide better care. So I actually had a second-year observer with me in the department yesterday, and at one point I was writing an antibiotic script, and she said, I actually was just looking that up, and I think the dose that you wrote might be the wrong dose. I've been doing this for 8 years. Who is this second-year medical student telling me that I've written the wrong dose. That could be one response, or the other response might be, oh my gosh, you're right. Thank you for, thanks for helping me identify that. Or, double checking. And it could be that I've ordered the perfectly correct dose, but taking into account this perspective that somebody else has, valuing it, and going from there. Turns out I had ordered the wrong dose, and we were able to correct that before the patient went on their merry way. One of the PCAs, while I was sitting at the desk, came up to me and said, this lady that you're looking after in room 4, I don't think you've updated the family yet. I think they'd appreciate that. This is particularly important during COVID because families can't be in the emergency department. I often have a million things going on. They're spending more time with the patients. And this was a really helpful reminder for me that there was something that needed to be done, but required a little bit of going out on a limb, because in some ways, this is the PCA telling me that I haven't really kind of fulfilled all my duties, and could be kind of interpreted perhaps with some tension. The PCA was right. The family did really appreciate it. And then, geez, the most dangerous thing we do in emergency medicine is send patients home. And we usually get that decision right, but every once in a while we get it wrong. And if you're lucky, if I'm lucky, our excellent charge nurse or my excellent nursing colleagues will help me sort out maybe when I am getting that wrong, or maybe when we're getting that wrong as a team. And so I was looking after an older gentleman who came in with dizziness. I did all sorts of tests. I didn't really find a reason for him to be dizzy. And I thought that I could probably get him home safely. I wasn't thrilled with the idea, but I thought we could do it. And just before I was about to discharge him, the nurse came over to me and said, I'm not sure this is the right decision. And again, he had spent much more time with the patient than I had walked him up to the bathroom, had a bit of a better sense of what his home situation was. And I think in this moment, my nursing colleagues prevented me from making a really bad decision. It was a bit frustrating because keeping this patient in the emergency department and handing them over to my colleague without a really good reason, and without, a specific sense of what was going on, it was a bit of a burden, and it was more work for me. And getting this guy home would have been easier, and everybody except the patient would have been happier. But this is fundamentally why we practice medicine as a team sport, so that we can check each other, so that we can really do best and do right by patients. So these are 3 simple circumstances from my shift last night, where people that I was working with had to kind of challenge my decisions, or had to tell me what they really thought. What I worry about and what I lose sleep about is, what are the situations here that I might have missed out on? Who on my team maybe didn't feel like they could actually have these type of same frank conversations with me? And I'll never really know that. But in a few minutes, we'll talk and think about what are the ways that we can actually foster cultures and foster teams where this is the norm, where this doesn't feel unusual. Now, we aren't really the only groups of people that should be thinking a lot about psychological safety. And in fact, a lot of this background and a lot of this theory comes from domains that are not medicine related. Some of the folks who have been reading the Culture Code with me this fall, which is a book specifically about organizational culture, will recognize a couple of these examples. The Navy SEALs are specifically known for developing and maintaining teams with high levels of psychological safety. You can imagine that for this team, being able to take interpersonal risks with each other is extremely important. In fact, it is what they do on every single mission. Not only are they trying to look after patients, they're trying not to die themselves. So for Navy SEALs, psychological safety is absolutely imperative. And what I was a bit interested in when I was reading this book called The Culture Code by Daniel Coyne is the very specific ways that the Navy SEALs train and work together with the explicit objective of developing psychological safety and fostering it. That is something that I don't think we are as explicit about in medicine, and that I think was a big kind of takeaway for me. But there's other industries that have to do this as well. One of my favorite examples in this book was the kind of culture that exists at Pixar. So every Monday morning at Pixar, the whole company essentially gets together to watch reels from the films that are being developed. This is everybody from the barista all the way up to the CEO. And the only role of this Monday morning meeting is to go through these reels and figure out what's going wrong, figure out what could be done a little bit better. And everybody is involved in that process. The result is that we get awesome films, really films that have changed the industry in some way. The funniest example, and one that I think is kind of the neatest, is actually doesn't come from a realm of industry that is at all legitimate. It comes from an example of kind of the top tier jewelry thieves in the world. There is apparently this kind of gang of jewelry thieves that is notorious for stealing everything from everybody in all the fanciest ways, in ways that should essentially be impossible. And the way that they do it is through teams that have strong sense of collectivism, and in that, strong levels of psychological safety. So I think, medicine has a fair bit to learn from these other industries that are very designed very explicitly to foster a sense of psychological safety within their teams. So as we think about in medicine and in the teams that we work in and in healthcare, building psychological safety, this seems like a little bit of a gargantuan task. We're often on teams that are shifting and moving. We are, we're too busy, we're too under-resourced. But I think of anything, this is something that we can do deliberately with the people that we work with every day. So whether it be in your classes now, whether it be actually on this council and group that you've created here, we can think about what are the ways that we're going to build and foster psychological safety in these teams. And I think you'll find once you start doing it, it becomes like a little bit infectious, actually. Making people feel like they belong and helping people belong and helping our teams bond is actually a whole bunch of fun. It's a contagious kind of feeling. And there's actually some evidence to support the fact that psychological safety actually spreads like contagion. So there's some modeling done by engineers to show that within communities, there can be these nodes of psychological safety. And if you really make a deliberate effort to make certain groups of people feel psychologically safe, that then this will spread kind of much in the way that COVID-19 does. So with some deliberate effort, we actually can have a very positive effect. I'm a pretty simple person, and I, at the end of the day, like to have, at the end of the shift, no matter how busy it was, no matter how hard it was, I like to think about kind of two simple questions that I can chat about with my team that will allow me and allow us to start thinking about our work together. And really that process of being a bit reflective about our day or about our shift is one really simple way to start building psychological safety, because it shows that you value people's input, and it shows that you importantly have a future together, because you're starting to think about how can we get better. And that sense that we belong to something is a really important part of psychological safety. So I ask my teams, the nurses that I work with, the learners that I work with, the other physicians that I work with, just two simple questions, sometimes at the beginning and sometimes at the end of the shifts that I have, always at the end of kind of high stress situations. And these questions can take just a short period of time. I think they're questions that you can ask your groups that you're working in and the teams that you're working on. Pretty simple questions. What's working? What went really well today? What are we proud of today? Is kind of that first category of questions. So getting people chatting about what went really well. And there's no doubt in healthcare, there's always things that go well. It doesn't necessarily feel that way all the time. But at the end of the day, leaving the emergency department, leaving the OR, leaving the public health unit, there are things that we can be proud of, and we need to identify those and get jazzed about them, because the work that we do is excellent. But having said that, we can always push ourselves to get just a little bit better. And this is actually where this kind of idea that we have a future together, I think, comes in. So it's like, when we show up tomorrow on this shift, what are we going to do just a little bit differently to make this experience better for our patients, better for us? And this idea that we actually have agency and control around improving our work as a team, teams that kind of learn together and grow together, we know have high degrees of psychological safety. So these two questions, very simple and pretty easy to ask, are a good way to start deliberately fostering psychological safety. This works in all sorts of environments. So getting a patient from the emergency department or from the ICU down to the CT scanner fast and safe is a challenging thing to do. We've worked for over a year with teams figuring out what is the best way to do this, asking two simple questions: what's working, and what could we do just 1% better? We have found that actually one of the best ways to make this happen efficiently and safely is to put the porter in charge of the transfer process. So they're actually like the team leader of the transfer, because this is what they do day in and day out. If we put them in that leadership role, and the physician is still there managing the airway, the nurses are still there with the medications, but the porter is driving the transfer train. We found that to be kind of an effective model. We can think about it in operating theaters after cases, or at the end of days: what went well, what could go just a little bit better. These conversations can happen anywhere, and really, if we commit to having them, we can, I think, really impact our levels of psychological safety within our teams, and get a bit reflective about the way we do our work. This is critical to do, because work in healthcare, whether it be where I work in the emergency department or whether it be in any healthcare setting, the work that we do is uncertain. The work that we do is high risk, and the work that we do requires us to be as strong a teams as we possibly can be. The piece that I really want to highlight to this group is these types of conversations and these types of questions can start with students. It doesn't have to be it doesn't have to be me being the boss of the emergency department, whatever, to have these conversations. Anybody can do this, and so you play an absolutely critical role on the teams that you rotate through in the hospital, and the teams that you rotate through in generating psychological safety. Thinking about psychological safety as well while you rotate through different teams, I think for me, actually, throughout training, was a little bit of a protective mechanism, because you're rotating so often, and there's some teams that just feel right and feel good and feel like you want to be there, and there's some teams that you don't have those feelings as much about. And this is actually how I got interested in organizational anthropology. I was really interested in diving into what is it about those teams that I feel like I belong to. In retrospect, it was simple things. It was them like physically inviting me to the table at rounds instead of sitting on the outside of the room. It was a clear introduction about where I should put my bags and where I should eat lunch. Really kind of simple human and team behaviors to get us all functioning at our best. So with that in mind, I will stop sharing here. And I thought what we might do is have a bit of a chat about first any questions that anybody has, and then maybe think about, for this group in particular, how we might think about kind of making it as psychologically safe a group as possible, and what actions we can take as individuals and as a group kind of moving forward.
Thank you for this talk. Yeah, so I think everyone here agrees that this topic is super relevant and often overlooked. So thank you for all of your stories and the insights. So if anybody has any questions, feel free to speak up or to type into the chat.
I don't have a question, but instead I have a comment. Dr. Purdy, when you were talking about the different kinds of aspects of a group that might invite you towards them, like groups that have a bit more of that psychological safety, I couldn't help but to think about my own experiences. And I find that typically when I'm invited by like when other people have smiles on their faces, I find that really draws me towards them and I feel, hey, I feel a little bit safer in this group. So I'm wondering if that's also, maybe it's just a me thing, but that's kind of something that really resonates with me when it comes to psychological safety.
Yeah, I mean, so there's quite a bit of work to suggest that like teams that have alarmingly high levels of eye contact are extremely psychologically safe in our cohesive units. So like anybody else that like goes into that environment as an outsider is kind of like, what is happening here? Like, why are they looking at each other so much? But we know that that's important. And interestingly, in COVID, you know, one of I think the biggest issues in the hospital right now is that everybody's face is covered. Obviously, has to be. But as we walk down the hallways, we can't smile at each other, which is a very normal and kind of like primitive way to suggest that you belong to something. And without that connection, you don't feel as tied to an organization or a group. Another thing that is very common in kind of psychologically safe and high functioning groups is like a lot of contact. So a lot of, you know, shoulder taps, a lot of fist bumps. And again, in COVID, a lot of those things are actually limited. Now, these teams wouldn't tell you that they know that they're doing that, but they are.
Related to that, since most of our meetings are online now and even class is all on Zoom, is there any way where we can facilitate the same kind of acceptance? It's kind of hard to like stare and expect that, you know, I am actually looking at you when I'm looking at my screen.
You know, that is such an interesting question. And I think that it's going to be something that ends up getting researched quite a bit out of this. So we know actually in terms of meetings that the degree of psychological safety that's necessary in order to break the barrier to kind of speak up on Zoom is actually dramatically higher than it is in an in-person interaction. In the same way, for a person who's chairing a meeting, you can't use the same cues to invite people into that conversation. And so I've done some work kind of consulting with people about what are ways that we can actually build inclusivity very deliberately, which I actually am not sure that I've done the best job of in this setting. So one of the most effective ways to do that is actually to get everybody talking at the beginning. So a quick introduction and a discussion, you know, usually where I would start would be, today we were doing a seminar on communication for our residents, and it would be, you know, tell me something that you think we do really well in communication, or tell me about the last communication incident with a patient that you think went poorly, just to get people talking. And that oftentimes that initial barrier is something that can be broached, and then being very deliberate about gathering perspectives from people. So saying, Samantha, you know, we haven't heard from you in a while. Do you have any thoughts on this? Or saying to people, I'm going to give you 1 minute to think about X, Y, and Z. And then we're going to come back together and talk about it. So there are very different social norms in the online world for sure.
Sorry, I have something to add to this. Just from a different perspective, which I found really cool about your story, is I actually do the access control screening at KGH. So it was my first time in the, sorry if this is a bit of a tangent, I'm so sorry. It was my first time in the ER this past weekend. in ER before, other than like taking my parents or something like that. But I was actually quite surprised to see how well it actually worked all together. And I thought that was really cool, especially seeing triage and security all there. But I don't know if I just want to put that in there because you're talking about different perspectives with like the environmental services as well as nurses and everything else. So I just thought I'd put my 2 cents.
Yeah, so is the access control screening like screening people coming into the hospital?
Yeah, so for the ER entrance, we just take care of like patients that can take themselves into the ER. And then there's like your staff entrances where we see the doctors come in, which I always find very fascinating. And then as well as just main entrance kid babies where we see visitors. So that's definitely very different. But yeah.
So, it's interesting. I was talking with with one of my colleagues right at the beginning of the pandemic. And there was something, again, from a belonging perspective, about showing up and being greeted by somebody at work every day. That was really quite profound, especially in that time of uncertainty. And having the screeners there sure was great for screening, but I actually think from a like psychological safety perspective of the hospital, having somebody come in and say, "Hey, how are you today?" As you're coming in was really a really important piece of that. And this isn't rocket science. Like that's what Walmart does with greeters. That's literally the reason they're there, is to make you feel like you like belong and want to buy things from them. So it's it really though it was quite nice. There was something like warm and fuzzy about seeing people, and we still get to see people every day when we come into the hospital. And it wasn't something that I had thought about as an outcome of that. It seems like a very, rigid process. We have to screen people. But like we were all a little bit disappointed when it became originally it was like a verbal, you were talking to a person getting screened.
Yeah, I agree.
And then it was just kind of sad. We were all a bit bummed.
Yeah, I still put in the extra effort. I say hi and how you doing? And then I say, have a good night. And some people say that back and then other people just walk out. But it goes with the job. Pardon? Yeah, some people just walk out. It's really sad. But well, I'm doing my part. But yeah,
That's totally sad.
Yeah, I mean, when I first started, I'm not gonna lie, I was a little underwhelmed. As soon as I saw the scanning and the badge, I was like, well, this is not it. But some people are really nice, and I think that I personally enjoy patient entrances the most. But it just goes back to that whole like feeling like you belong and like the whole psychological aspect of that. So yeah, that's just my little story.
Well, and it's what you think about like patients who are coming in nervous about COVID and about the new different. I mean, I'm nervous when I go into a hospital as a patient anyways, and like I know how hospitals work, let alone being somebody who's a patient who's maybe at risk, who doesn't know what's happening with COVID. And probably that first like 10 or 15 second interaction that they have with you is totally crucial to making them feel psychologically safe in this environment. And I've only talked about people on our care team, but it is equally as important that patients feel psychologically safe, and families do, right? That they can say, I don't think this is right. Like, I don't think we should go home, like, or have as important kind of a role in that. And we have a real job to make them feel psychologically safe as well, and can do so using some of exactly the same kind of the same tools that we have to make each other feel psychologically safe.
I had one question with the whole idea of creating a more open environment for more questions to be asked and more ideas to be brought up. You're going to get more people like obviously bring up ideas. What do you kind of do to maintain the psychological safety in instances where it's like inappropriately brought up or incorrectly? Because I've been the medical student who said like, oh, maybe the dosage is wrong. And they're like, no, the dosage is right. You're wrong. And like, there are different ways they go about saying that. And it kind of changed the way I would then approach the next one. So do you have any tips for like how to maintain that psychological safety, even if it's not correct necessarily?
Yeah, and so I think that's actually the crucial moment, right? Because it's easy to incorporate people's ideas if they're correct, because then you're like, oh, okay, like great, this is awesome. But that you're probably where your psychological safety is at the highest risk of being like totally destroyed is when you're wrong. And so I think there are really kind of key ways to do that. So let's say last night you came to me and said, oh, I think it should be 600 milligrams, not 500 milligrams. I'd be like, oh, you know, let me just double check that because you totally might be right. And then we'd look it up together and we'd see that maybe it's actually 600, not 500. And I'd be like, oh, thanks. You know, mostly I'd want to say thank you for bringing your concern up. And this is a bit of a funny circumstance because it's not like a huge, you know, it's not like a huge thing. But kind of the higher risk the circumstance, the more I validate them having brought their concern forward. So let's say it was the janitor who came to me after I was doffing and said, you know, I saw you doing that, doc, and I'm worried that your bouffant should come off before your mask. And let's say that's not the case, right? Like, let's say that I had doffed properly. I would say, hey, let's go over this checklist together. I know you've been doing this for way longer than I have. I really appreciate you bringing this forward to me, and I want to make sure I'm doing it right. So let's go through it. Because I want that janitor to keep telling me things if they think they're wrong. And if I shut them down there, the risk of them never saying anything to a physician who's doffing improperly again is like sky high. So I think we have to pay the most attention when people are wrong. And it comes up not infrequently for me in resuscitation. So let's say we are resuscitating a patient and I'm working with a junior resident or a medical student or a senior resident or another colleague. And they may have a suggestion that in the moment, I really don't think is right and is going to take us off on the wrong path. And perhaps we need to be making quick decisions. And so sometimes I will just like you'll make the decision and go with it, but I will, as best as I can, make an effort to go back to that person later, an hour later in the shift and say, hey, I know you suggested it. I didn't incorporate it into what I was thinking at that time because of X, Y, or Z, but thanks for your suggestion. So there are times when maybe you can't have that long conversation right in the moment. But that's where kind of building in time for reflection as a team at the end of the day, maybe when you do have a little bit more time, is helpful. So let's say you and I, again, will take the kind of example of the prescription and say, what are you really proud of today? And I might say, look, I'm actually really proud that you told me that I was doing something wrong. That is what I think went awesome today. So I will oftentimes try to kind of build in those moments, like, kind of when I can, even if it's not right in the moment.
Awesome, that's really good tip. Thanks.
And I think the kind of higher the power gradient, the more deliberate and explicit that kind of effort has to be. There's another concept in team science, basically called, what is it called? There's an excellent blog post that I'll forward along to Minnie to send out. But basically, it's this idea that with praise, or when somebody has done something right, we need to be very explicit about what the action was, and then associate that action with an impact on me. So I would say, look, I really admire and I'm really happy that you brought up that kind of concern around doses. That impacts me because it makes me feel more confident in what I'm doing, because I know that I've got a team that is kind of helping me along the way. And so then you leave feeling, one, that you did the right thing for bringing up a concern, and two, understanding why it's important. And the kind of bigger the power of the gradient, I think the more explicit those conversations have to be. But having said that, we can have them with our peers. So I, not infrequently, with one of the recess nurses, at the end of a recess, we'll sit there and have a quick chat. What went well? What could go just a little bit better? What are we proud of in this situation? But it perhaps is less kind of formal and less obvious, but is the same kind of idea. Let me find this blog post right now and I will add it on. All right. There we go. So, in the spirit of psychological safety and reflections, when I think about this talk tonight, one thing that I am really proud of is, I think, kind of bringing these undertold and perhaps quieter stories of our colleagues that work their butts off in the hospital, kind of to the forefront of what is the more visible kind of face of healthcare, is something that I am proud of doing and want to kind of continue doing, is bringing these like untold and perhaps less heroic stories to the forefront. One thing that I think I could have done a little bit better is we should have had a little bit more. I wish in my presentation I had built in kind of a little bit more audience engagement and some more kind of focused chats as we went along. So as I use this presentation again, I will redesign how to do that a little bit more effectively. Maybe Minnie, in terms of the series so far, in the talk so far and how things are going, what are you most proud of?
I think I'm most proud of the team coming together and putting together these talks and putting together these programs, because it was very new, and I think we weren't sure if our vision was going to keep moving forward, because we hired an entirely new group of people to come in. And I think everybody has actually worked very well together. And even though we didn't know each other from before or from different departments, I felt that everybody had a common goal and actually worked really well together, talking to each other, coming up with new initiatives and being brave enough to do so. So I thought that was really good so far. I think the 1% thing that we could do better as a group actually is to have even better communication with regards to our expectations of each other. And then I think that goes back to feeling comfortable enough that we are able to kind of check in with each other and say, oh, has this been done? What are your expectations on when we should get things done? Because that's always a little bit difficult. You're always worried about, oh, am I being too demanding? Am I like overstepping? I don't want to seem like I'm being bossy or anything. And I think that does also require a certain level of comfort and safety with everybody to start to reach out, and then to make sure that we are communicating everything and we are communicating our expectations too.
Yeah, and Minnie, it's interesting when we think about kind of building psychological safety, there's ways that we can kind of structure our organizations or our groups to help a bit with that. So if it comes to kind of timeliness of communication or not knowing kind of what's the right amount, you can actually build into your organization ways to do that. So it's like, you know, we're going to have a once every 2 week update that goes out. And if you have anything to add to that, just send it along to me in advance so that there's like something that's structured, and then people come to expect it and they feel safe because they know they're going to get information. And so I get excited in thinking about like, what are the systems that we can put in place that don't rely on, you know, don't necessarily just rely on people stepping up or speaking out or wondering, you know, what's the dance of how this is going to happen. It's like, what can we do within our organization structure to make sure that we build in psychological safety? So you guys as a group could end up talking about, you know, just have a good conversation about like, how often are we going to communicate at a minimum, and what will that, you know, what will that look like for people? Brittany, what are you most proud of?
I think Minnie took the words right out of my mouth. I'm one of the new hires for this year. I'm in first year OT, and stepping into this, I was very nervous. I wasn't really sure what to expect, and I knew that there were expectations coming into this role. I think I'm also really proud of how well everyone has worked together so far. It seems that we were able to kind of blend each of our energies together, and then like everyone sort of found their own position in the role. And I think I really appreciate how I can always rely on my team members to help me sort through something if something goes awry.
Yeah. And what do you think? So it's interesting when we think about new people coming into organizations, because oftentimes they're a good kind of like measure of, or good barometer of the psychological safety, because people who are within the group, for a group that's high functioning, tend to feel psychologically safe, but aren't necessarily good at like making people kind of feel on board with that. So if you were in charge of welcoming kind of a new member onto the team next year, what would be one thing that you'd change to make them feel like they belong a little bit more quickly?
This is a little bit of a challenging question, but I know we weren't able to do this year because of COVID, but I would really like to have just an in-person gathering where all of us meet each other for the first time in person, maybe some sort of like potluck or just a little welcoming party. Um, I think in terms of a little bit more documents wise, I would have really liked a transition report just so I could envision everything that KHealth has done so far and then see where everything has been left off and where we can take that as the new group of people. So, and maybe something to keep in mind. Actually, probably something for me to keep in mind as I welcome the new groups next year.
Yeah, so this conversation was mostly just meant to be a bit of a demonstration that by asking two really simple questions, you can actually get at some like deeper level kind of organizational things that we can actually action on and take some tangible steps towards. So those are exactly the types of conversations that you can have with each other, you can have with your classmates or teammates, and that you can have in the hospital. So I hope that this was helpful. If you want a good read and you haven't read it already, Daniel Coyne's The Culture Code is excellent and really dives into some of these in a really readable kind of pop culture nonfiction read. So would definitely be worth checking out.
Yeah, and thank you so much again, Dr. Purdy, for joining us today and really being, I think, very authentic and very open with us. So yeah, if anybody is interested in joining that book discussion group, you can also contact either Dr. Purdy or I, and we can add you into that group. And I think last but not least, we have some last updates from Brittany.
Yes, so I'd also like to thank Dr. Purdy again for her insight on psychological safety and interprofessionalism. And I will do my whole KHealth spiel again. So for those of you who may not know me, I'm Brittany, and I'm one of the ICHP coordinators for this year. I just have two quick announcements to make. Since there might be some of you who don't know, KHealth is an interprofessional group of students interested in working together to help vulnerable groups in the community. And this event today is part of the ICHP, which is an educational component of KHealth. The ICHP is a program developed by KHealth that focuses on serving vulnerable populations in an interprofessional setting. Upon completion of the program, you will receive a certificate. And aside from the ICHP, there are volunteering opportunities. During a time such as this, we recognize the challenges that our community members may be facing. So we do deliver groceries and connect through phone calls with the community and hope to volunteer with meal programs in the future as well. If any of this sounds interesting to you, please visit our website, Facebook page, or email us for more information and all those links I will put in the description box or chat below. And second thing is our feedback form. We would really appreciate it if everyone could provide us with a little bit of feedback regarding the talk today. If you are an ICHP participant, please also use this form to verify your attendance for this talk. Please note that without completing the form, we won't have a way of checking whether or not you're present at this event. And another note for ICHP participants, we would also like to inform you that the email with all resources and links have not been sent out just yet due to some logistical issues regarding our components. So we truly apologize about that, for the delay. And we're in the midst of sorting everything out, and we will send a post to our Facebook page as soon as we have all the links and resources mailed out to you. So thank you for your patience. Whew. There it is. And I will take it back to Minnie to close off our session.
Yep. So thank you again, everybody, for coming today, and then especially for Dr. Purdy for sharing her time with us.
Thanks for having me, guys.